Hello everyone. In this particular class, we'll try to learn how to examine the cranial nerves 3, 4 and 6 which are related to the ocular movements and how to examine the trigeminal nerve, that is cranial nerve 5. The oculomotor, trochlear and abducent cranial nerves, these are purely the motor nerves innervating the extraocular muscles. Trochlear nerve is going to innervate the superior oblique muscle, abducent is going to innervate the lateral rectus, and oculomotor nerve is going to innervate other extraocular muscles and levator palpebrae superioris. And it also contains parasympathetic nerve fibers to constrict the pupillae and ciliary muscle. How to examine these cranial nerves in sitting posture? First, observe for the ptosis and nystagmus if at all they are present. Then you have to test ocular movements, for which the head of the subject is fixed with one hand and then the forefinger of the other hand, it has to be brought to the midline 30 centimeters in front of the subject's eyes. Then move the finger on either side horizontally and vertically upwards and downwards. The subject is asked to follow the direction of finger with his or her eyes without moving the head, and observe if the ocular movements are performed normally. So this is how one has to examine from the center. The finger has to be brought to the in a horizontal direction. So then the finger has to be moved in upward direction or downward direction. So then again bring the finger back to the central, and similarly on the other side it has to be tested. Then go upward direction or in the downward direction. So like this, the movements, ocular movements has to be tested. When the eye is uh, abducted, in abducted position, the elevation is caused by superior rectus and the depression is caused by inferior rectus. That one has to remember. And when the eye is adducted, in adducted position, the elevation is caused by inferior oblique and the depression is caused by superior oblique. In occulomotor nerve palsy, the paralysis of the levator palpebrae superioris and pupil is dilated, that it is going to lead to mydriasis. And the eye is deviated downwards and outwards. In trochlear nerve palsy, the eye is deviated inwards with the difficulty to move the eyeball downwards and outwards. So this is typically how in oculomotor nerve palsy you can see the eye is deviated to outwards and downwards. In abducent nerve palsy, the eye is deviated inward with the inability to move outward beyond the midline. The nystagmus is nothing but the oscillatory movements of the eyeball, and they can be horizontal, vertical or rotatory types of nystagmus. And strabismus squint is a deviation of the eyeball where the visual axes do not meet at the point of fixation. There are two types of squint: concomitant, that's paralytic squint, and non-paralytic squint and paralytic squint. Then you have to test the light reflex. There can be two types of light reflex: direct reflex or indirect or consensual light reflex. For direct reflex, ask the subject to close one eye with the palm of the hand. A beam of light from the torch is thrown to the open eye from the side to avoid accommodation response. And this has to be done in the dark room, and eventually it is going to lead to the constriction of the pupil on which the light is thrown. Then for indirect reflex, that is consensual reflex, both the eyes are kept open. A hand is placed vertically between the eyes, that is to prevent the light falling from the opposite side, and the light is shown on the one eye. So this causes both pupils to constrict at the same time. Note that the light reflex is lost in oculomotor palsy, optic atrophy, and with a blindness and tapes dorsalis. Okay, so this is the pathway for the light reflex. Uh, the afferent is optic nerve and the efferent is the third, that is the occulomotor nerve. Okay, and for the consensual reflex, because it occurs because of the bilateral innervation at the peduncle vespal nucleus and the pretectal nucleus. Note that afferent fibers, they are going to relay in both ipsilaterally and contralaterally. So that is why there is a consensual light reflex. Then accommodation reflex. Ask the subject to look into a distant object. Then bring your index finger close to and midway between two eyes. Now ask him to look at your finger. Observe the following changes. You observe there will be convergence of the eyeballs because of the contraction of the medial recti, and there will be constriction of the pupil. In addition to this, there is increased curvature of the lens. You can observe the convergence of the eyeball, and you can also observe the constriction of the pupil. But the increase in the curvature of the lens can be observed by using Purkinje's images. Argyll Robertson pupil is the absence of light reflex with the preservation of the accommodation reflex, which is seen in the neurocephalosis, where the lesion will be usually in the pretectal nucleus. So this is the pathway for accommodation reflex. The impulse reaches the optic nerve, then optic tract, lateral geniculate body, visual cortex. From there it goes to the area number 8, and area number 8, it is going to stimulate Edinger vespal nucleus of the third nerve, which leads to stimulation of the ciliary ganglion, which is going to eventually lead to the contraction of the ciliary muscle, and there will be increase in the change in the curvature of the lens. It is also going to cause a contraction of the constrictor pupillae, which leads to constriction of the pupil. At the same time, the area number 8 also stimulates the somatic motor nucleus of oculomotor nerve, which causes the contraction of the medial rectus, which leads to convergence of the eyeball. Coming to the trigeminal nerve, which is a mixed nerve, the motor nerves, they are involved in the muscles of mastication, and the sensory, they are going to bring the sensation from the face, that is general sensation from the face. The examination of this nerve includes the following function, that is the motor function, sensory function, and reflexes. Usually motor function is assessed by opening of the mouth, side to side movements of the jaw, and clenching of the teeth to test pterygoids, masseter, and temporalis muscles. Whereas for the sensory function, touch, temperature, pain sensation from the face is going to be assessed from all the dermatomes, that is ophthalmic, maxillary, and mandibular divisions. Then you have to assess the corneal, conjunctival, and Georger reflexes. The requirements required are cotton pin, glass tubes containing warm and cold water, and knee hammer. The procedure is subject is seated comfortably on a stool. For sensory function, test all the sensation in the 3 divisions of the nerve, that is ophthalmic, maxillary, and mandibular, separately, comparing the both sides. That you have to check all the general sensations like pain, touch, pressure, etc. Then to assess motor function, observe the muscles of mastication for wasting. While the subject clenches the teeth, the temporalis masseter muscles are felt for their firmness. Then ask the subject to open the mouth. Normally the jaw will be in the central, and usually the lateral pterygoid is responsible for the opening of the mouth. Then ask the subject to move the jaw from side to side against the resistance offered by you. So that means the grade of the power of the muscles will be grade 5. And to detect any weakness, so this has to be done to detect any weakness of the pterygoid muscles. Then reflexes has to be assessed. The corneal reflex will be tested with the subject looking up. There should be approach from the side and touch the cornea gently with a wisp of cotton, and then observe for the blink reflex. So there will be reflex contraction of the orbicularis oculi. Okay. So this reflex usually is not elicited because sometimes corneal ulceration can lead to blindness. Similarly, conjunctival reflex is done by touching the conjunctiva with a wisp of cotton to observe the blink reflex. For both the reflexes, afferent limb is ophthalmic division of the trigeminal nerve and the efferent limb is facial nerve. Then the jaw jerk is also elicited where the afferent and efferents are both the trigeminal nerve and the center is present in the pons. In trigeminal neuralgia, there is a spontaneous spasmodic pain over the half the face without any objective sensory loss. So this is the pathway of the blink reflex, conjunctival corneal reflex, where the sensory is trigeminal nerve, goes to the chief sensory nucleus or to the spinal nucleus. From there, the information goes to the seventh nerve, and seventh nerve, it is going to lead to the contraction of the orbicularis oculi. Okay. Then the report has to be written in this manner, that is the examination of the cranial nerves which are related to the ocular movements. Both the individual and the conjugate movements are recorded. And for the third nerve, the light reflex, the direct and consensual right reflex, accommodation reflex, and for the fifth nerve, the sensory, motor and reflexes should be mentioned. So this is how you are going to examine the cranial nerves which are related to the ocular movements and the trigeminal nerve. Thank you.